Hi. So today I want to talk to you about oxygenation and ventilation. Now, do you ever notice on the anesthesia machine it has your FiO2 and it has your FeO2, your expired oxygenation, right? And let's just say your FiO2 is 50%, for example, and your FeO2 might be 45%. And your minute ventilation's 5 liters a minute, just to get all the numbers out there. So you're breathing in 50% oxygen, and you're breathing out 45% oxygen. So you're consuming 5% oxygen in the mixture that you're breathing in. That seems like a waste, right? Now, I know oxygen's pretty cheap, but you multiply it out by the number of cases we have, stuff like that. What if we just gave 5% inhaled oxygen? That seems like it would save money, right? What would happen if you ran someone on 5% FiO2? They would probably get really hypoxic. But why? We just said they're only using 5% inhaled oxygen, right? So let's leave that to the side for a second. So you've been playing around with vents long enough. How do you blow off CO2 on someone? Increase their respiratory rate, increase their tidal volume a little bit. If you want to be fancy, you'd say increase their minute ventilation, which is just respiratory rate times tidal volume. So now here's a question for you. Does increasing your respiratory rate improve your oxygenation? If you're desatting and you turn up the respiratory rate, does that increase your sat? No. But why? I mean, CO2, O2, they're just gases. We're doing gas exchange. You're improving gas exchange. You're moving oxygen faster. Why doesn't that improve your sat? Why does oxygen and CO2 behave differently in the body? The primary difference between oxygen and CO2 is their solubility. CO2 is 25 times more soluble in serum under physiologic conditions than oxygen. If you had 100 cc's of serum, you could dissolve like 2 cc's of oxygen in there. You could dissolve 50 cc's of CO2. Think about like a can of soda. You can get a ton of CO2 dissolved in liquid. Or conversely, think of the oxygen content equation. Think deep down into your brain. 1.34 times hemoglobin sat plus something. The way I remember it is big number times hemoglobin plus really small number times dissolved oxygen. And the point is, oxygen is insoluble in your serum. You need a carrier to carry the oxygen. So now, why does solubility matter? To answer that, I gotta take you back. High school chemistry class. Think of diffusion across semi-permeable membranes. You have like two things, like two jars of things, and you have a semi-permeable membrane in between, and you're trying to get something to diffuse across to something else, right? In this case, we have the oxygen gas on one side, we have the liquid serum on the other side, and we have the alveolar wall in between. And we're trying to get the oxygen to diffuse across the alveolar wall. So think back to chemistry class. What determines the flow across that membrane? When I remember, it's something like concentration gradients, surface area, and membrane properties. So what controls the gradient across this membrane? Well, we can't really control the serum O2. That's just the venous O2 partial pressure. We can control the alveolar FiO2, right? That's the FiO2 we give someone. So if we change the FiO2, we're changing the gradient, pushing that oxygen into the serum where it doesn't want to be because it's not very soluble. So changing our FiO2 isn't so much about the amount of oxygen we're giving, because you don't really need that much oxygen in terms of the amount of oxygen we're giving people. What you need is a concentration gradient to push that insoluble oxygen into that serum. So now what about surface area? How do we change the area over which we're absorbing this oxygen? Well, the alveolar area, the whole lung area, what if we just change the whole volume of the lung? So if we increase the overall volume of the lung, we can increase the surface area over which we're diffusing. Now, volumes are kind of hard to measure inside the body, but let's assume that the chest has a certain constant compliance, which is not always true, but for now, let's assume that it is. Then the driving pressure that we give should correlate with the volume of the lung. The harder we push, the bigger the lung gets, right? So we can say as a proxy, not always true, that the pressure that we apply to the lung is a proxy for the volume. So instead of saying we want to blow the lung up volume-wise, we could just say we're going to apply a lot of pressure to the lung over a long period of time, and that's going to open the lung up. That's going to increase our surface area. So we can increase the FiO2 to increase that gradient. We can increase the pressure, i.e. volume, of the lung to increase that surface area. And then we get to membrane characteristics. Is there anything that can affect the alveolar membrane that's going to prevent us from diffusing? Sure, all sorts of things. The most common for us is usually ARDS, meaning the alveoli are just all messed up and full of pus. Or pulmonary edema, meaning the alveoli are all full of fluid, and that's getting in the way. So how do we increase the oxygen transfer into our blood? We can increase the gradient, FiO2. We can increase the volume, the surface area, i.e. mean airway pressure, or we can try to avoid screwing up our membranes, which we can't do much about, but we try and avoid if we can. So now, up until now, have I talked about breathing at all? Is there any real reason that we need to breathe to oxygenate? And this gets back to the solubility. We are exchanging CO2 25 times faster than we're exchanging oxygen. We are absorbing oxygen slowly into our serum from our lungs. But that is happening 25 times slower than we're filling up our lungs with CO2. So the reason why we need to breathe as often as we do is because our lungs are filling up with CO2, and we need to increase the turnover of that gas to make sure that we can keep pushing CO2 out at a fast enough rate. The oxygen in our lungs isn't getting used up that fast, so it could just really actually just sit there. In fact, oxygenation is a passive process that's going on throughout the breathing cycle. So if you think about what is the maximal amount of oxygenation you could impose on someone, turn the FiO2 to 100% and give them a sustained breath, opening up their lung as full as it possibly can. Is there any reason to release it? Once you've washed in 100% FiO2 into your alveoli, all you need to do is just keep it open, what we call a recruitment breath. That is the maximal oxygenation you can get. That's why minute ventilation, tidal volume respiratory rate, getting as much air as possible through your lungs, that's going to affect your getting rid of your CO2. Oxygenation, the limiting factor is usually the gradient and the surface area. It's usually not that you run out of oxygen. So keeping the lungs open, having a high FiO2, those are the things that are going to affect your oxygenation. Now, when I ask people about how to improve their oxygenation, the first thing they usually say is, well, add PEEP. Do you have to add PEEP? Think about what PEEP does to the lung. When you add on a sort of base layer of pressure, you're adding on a base layer of volume. So instead of titling whoop, 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 you're now wider and you're titling up here. What if instead of doing that, you just went, you took bigger breaths, you increase your tidal volumes. Is that going to increase your oxygenation? Think about averaging the amount of volume over time. It doesn't matter if I'm starting up here and I'm taking shallow breaths, or if I'm starting down here and I'm taking big breaths, or if, for example, I change my IDE, meaning instead of I go, as long as I'm staying open for the most amount of time that I can, that's going to increase my oxygenation. When I look at the monitor, I usually, whatever the color is that your pressure is, like if it's gray or blue or whatever that color is, I say, try and make the screen the most blue you can. Whatever you want to do. You want to move this up, move this over, just make the whole screen blue. If you want to maximize oxygenation, just hold a recruitment breath and it'll just be a big blue bar across the screen. Maximal oxygenation. So I hope this was helpful. I hope this helped you think through a little bit more about oxygenation, ventilation. I know you guys have dealt with this before, but I think a good conceptual understanding of what's going on helps you really get a feel for things.